Okay. So good evening, everybody. We will be discussing disc edema today. When I was a postgraduate, whenever I saw disc edema, I would be like a little freaked out, and I would go to my madam and say, "Ma'am, there is a disc edema. What to do next?" So my journey with disc edema has started since then, and we have evolved over the years. And I have a few facts and points that I want to share with you guys as postgraduates, how to recognize a dangerous disc edema and how to know what is not so dangerous. So let's begin. Why is it so important to know how to go about disc edema? It's a very common ophthalmoscopic finding, and you do not have a proper consensus or statistics about it because there are multiple causes for it, and these causes can be benign and to very life threatening or sight threatening conditions. Some of these conditions need urgent attention to prevent permanent visual loss, and some of these conditions can be a marker of ominous or life threatening conditions. So should be this disc edema should be investigated as an emergency. So broadly, I would like to classify disc edema into three categories. Pseudo disc edema is not actual disc edema, but I want to highlight on this because it simulates disc edema and causes a lot of confusion in many clinical scenarios. This group usually includes congenitally anomalous discs, physiological variations, and a few pathologies. The next condition is more deadly, and it's papilledema. By definition, it is always associated with a raised intracranial tension. So whenever someone says papilledema, you know you're dealing with raised intracranial tension. It's usually bilateral, but that doesn't mean if it's unilateral, it is not papilledema. It results from axoplasmic stasis that causes intraaxonal and extraaxonal swelling later on. The next group is optic neuropathies, which is characteristically unilateral and associated with deficiencies of the optic nerve functions. So what are these optic nerve functions? I'll tell you in a while. It can be bilateral and doesn't mean that just because it's bilateral, it is not optic neuropathy. Okay, there are multiple local and systemic causes for this. It's not going forward. Yeah. Okay. So first, the first step in evaluating disc edema is to know whether it's disc elevation or disc edema. They're both not the same. Okay, so disc elevation or pseudo disc edema, there are few important points for discrimination, and not all these points are true in all cases. However, whenever you see a hyperemic disc with a lot of peripapillary hemorrhages and hard exudates and cottonwool spots, we are probably not dealing with a pseudo disc edema. So they are predominantly absent in pseudo disc edema. The nerve fiber layer is opacified and edematous in true disc edema, whereas it is normal and sometimes may have defects in pseudo disc edema, especially seen in optic disc drusen. The large vessels are normal in number, however, they are tortuous and dilated in true disc edema. In pseudo disc edema, they are normal in caliber but may be abnormal in number if we are dealing with an anomalous disc. I have highlighted spontaneous venous pulsations because it is the most important characteristic which helps you to distinguish papilledema from a pseudodisc edema. I'm using the term papilledema here. Spontaneous venous pulsations are seen on the disc surface. You concentrate with your 90D and look at the vein, and you will see it pulsating in around 80% of patients. If you don't, then gently indent the globe and you can elicit these pulsations. They are absent when the intracranial tension raises above 190 mmHg. Okay, and the last one is optic cup, which is filled in true disc edema and which is normal in pseudo disc edema. Now, these are the causes of pseudo disc edema, hypermetropia being the most common. I'll discuss each of these in detail. These are the causes of papilledema. ICSOL and IIH should be given due importance because these are the common ones we are dealing with. The next is the causes of optic neuropathies, which include inflammatory optic neuropathies, ischemic. I have written anterior here because posterior ischemic optic neuropathies do not cause any manifestations of the disc in acute stages. Infective optic neuropathies and parainfectious. Infiltrative optic neuropathies And the last three usually present with more of optic atrophy. Very few and rare cases you get optic nerve edema. The most important in systemic conditions that can cause disc edema is malignant hypertension, uremia, anemia, ocular hypotony, and very high IOP, more than 45 to 50 mmHg. If the cornea is clear and if you are able to see the fundus, you will see that the disc is edematous. Most of the time in this high IOP, the cornea won't be clear. Then posterior uveitis and posterior scleritis. Can someone in the audience answer what kind of, give me one example of posterior uveitis that presents with bilateral disc edema? A very common.
VKH. VKH
Yes,
could have.
very good. Very good. Then central retinal venous occlusion and papillophlebitis, and tumors and malignancies of the disc. Excuse me. So how do we work up a case of disc edema? Like any other case in ophthalmology, we started with a good clinical history pertaining to the positive and the negative symptoms. The onset, the duration, associated features, associated neurological features, systemic features, everything is important. And once you finish the examination, go back in your history and complete the history. Then important ones are in examination are gaze and extraocular motility testing. Always look for an LR palsy when you're suspecting papilledema. And now let's highlight the optic nerve function tests. Okay, visual acuity, color vision, pupillary reaction, and visual fields. These constitute the four important optic nerve functions. Of course, there is this contrast sensitivity also, but we rarely check it in the clinic. So these four help you decide whether the disc swelling is associated with a dysfunction of the optic nerve or not. And thus it will guide you towards your diagnosis. Amongst these, I really respect the pupillary reaction a lot because this pupil will never give away. It's infallible. It's an infallible test. So even though there is optic neuropathy, you can have a good visual acuity or color vision, or the fields might be normal, but the pupillary reaction is never normal. Then a good and thorough dilated fundus examination is very, very important. Okay, this cannot be underscored because just looking at the disc to an undilated pupil and saying there is disc edema and the diagnosis is this is wrong. You want to see the rest of the retina, and I'll give you examples in the coming slides that will help you understand this. Then once you are done with all this, you grade the disc edema. Remember, this recent grading is only for papilledema, not for optic neuropathies. Okay, so there is a highlight on the optic nerve function test so that all of you remember this. Pupillary reaction also. Okay, now this is a picture showing you the grades of disc edema. This was described by Friesen way back in 1980s. So the first grade is grade 0, when there is no papilledema, but there is an increased prominence of the nerve fiber layer. Okay, it looks like disc edema, the disc is actually flat. Okay, grade 1 or very early papilledema is there is, if you see, I have marked N and T for nasal and temporal. There is only nasal obscuration of the disc margin, whereas the temporal is still okay. There is no halo there. Could any of the postgraduates tell me what the red arrow indicates?
Pale and slimy.
Very good. Can you describe them?
Next to the disc.
You're right. Right.
Retinal folds,
Very
usually because
the enlarged disc or the edematous disc pushes the retina away, and you see some circumferential folds along the retina. Okay. So next is early papilledema or grade 2, where you see a complete peripapillary halo with elevated disc and obscuration of all the borders. Then there is moderate papilledema with which is grade 3. In this you have obscuration of all the borders and obscuration of one or two segments of blood vessels over the disc. Then the next grade, you will see there is total obscuration of one particular vessel over the disc. And the last grade is severe papilledema, where all the vessels are obscured. The disc assumes a dome-shaped position, shape, and then the cup is filled and obliterated. Okay. So once you're done grading, you proceed to the next set of tests. But I want you to learn these mechanical and vascular signs of disc edema, which is available in any book and you can read about it. So the next important test, I always emphasize on blood pressure. Even though you do not have any signs of hypertensive retinopathy on the fundus, high blood pressure or malignant hypertension can always present with isolated papilledema, disc edema in both eyes. So blood pressure will be your first test, followed by visual field analysis. So what is the use of doing a visual field analysis in any case of disc edema? Anyone? What will you achieve by doing a visual field analysis? Some examples, can you give me?
Ma'am, neurological or whether this thing AION, that
Very
could
good.
be,
Altitudinal field effects
Yes,
can be
good.
made out.
Very good.
and optic neuritis will have central paracentral scotomas.
Very good. Very good. Also in papilledema, you can see the enlarged.
Enlargement of the blind spot.
So in papilledema, visual field is more of a follow-up use. Okay, you cannot use it as a diagnostic criteria for papilledema. The other two, what you said is exactly right. Okay, then OCT we can use to measure the RNFL thickness around the optic disc and macular ganglion cell layer. These are also not sensitive markers for disc edema or papilledema. It cannot help you to differentiate between any of the three conditions that I told you, pseudodisc edema or papilledema or optic neuropathy. It just helps you to follow up the disc edema. Whereas B-scan ultrasound has a special place in my heart because it can nicely show you if there is raised intracranial pressure or not. So in this we do something called a crescent sign. You have to elicit a crescent sign. Anybody knows what it is? When you place the probe in a transverse scan position, you see the optic nerve sheath. Okay, the optic nerve sheath diameter is measured 3 mm behind the optic nerve head, and anything more than 3.5 mm is taken as high, and it correlates with the degree of intracranial tension. So the higher the intracranial tension, the more will be the width of the optic nerve sheath. Okay, and then you will see one echolucent ring like lucency, which is known as the crescent sign. I'll show you the pictures in the coming slides. Okay, so this is diagnostic of papilledema. You can also pick up drusen using B-scan. Okay, then neuroimaging and CSF analysis only in required cases. I'll show you the pictures. So from the discussion till now, two important things I want you to remember is spontaneous venous pulsations and crescent sign. So I'll show you this video. If you have not seen till now, how a venous pulsation looks. Okay. This is not recorded by me. I got it from YouTube, but it's a very nice one. So I want you to see it. All right. So let's move on. This is the most important slide for today. Okay. I want you all to understand this. So whenever you come across disc edema, look for the optic nerve functions. Is it preserved? Then look for spontaneous venous pulsations on the disc. If it is present, then probably you're dealing with pseudodisc edema. Of course, this is not a foolproof algorithm, but it holds good for many of the conditions. If spontaneous venous pulsations are absent, then your diagnosis goes in favor of papilledema. Now, coming back to the optic nerve functions, if they were deranged to begin with, then don't think of anything. You're dealing with optic neuropathies. But there is a catch here. Sometimes papilledema can also present with visual loss. Okay, that might be due to associated macular edema, or if there is associated atrophy that has already set in due to high pressure. So, like in medicine, not everything is infallible. You have to again depend on more tests to ascertain your diagnosis. So let's deal with the causes of disc edema, pseudodisc edema one by one. The most common of this is hypermetropia. There is no history or there is no symptom as such. It's usually seen in more than 4 diopters of hypermetropia. On examination, you will see normal features of hypermetropia like a small disc and small cup, silk short retina, and the disc looks juicy and margins look elevated, but the vasculatures are normal and there is SVP. So you don't need to do any tests and the diagnosis is usually straightforward. The next of the differential diagnosis is drusen. If you see the picture here, the disc certainly looks elevated. Again, they are usually asymptomatic. They can have sometimes transient obscuration of vision. On examination, you'll see a lumpy, bumpy elevation of the disc. There is no hyperemia. The vessels are normal, and spontaneous venous pulsations are usually present. They may also have retinal nerve fiber defects and field defects. So diagnosis is established by hyperautofluorescence. If you use a autofluorescence, then OCT also shows hyporeflective lesions within the optic nerve head. B scan and CT scan also help you to pick up the hyperechoic lesion within the optic nerve head. The next is myopic oblique insertion of the disc. Okay, it's a little different from the tilted disc syndrome. Here, the disc is attached to the eyeball in such a way that the nasal border, if you see here, looks elevated and the temporal border is flat. It's usually seen in myopic astigmatism. And a OCT line scan of the optic disc is shown here. You will see clearly that the nasal margin is a lot higher than the temporal margin. Okay. So you may also see other features of myopia in the fundus. So usually no tests are necessary because it's a straightforward myopia. The next important category is vitreopapillary traction, which is coming into light a lot now. It's more common in older age group and following surgeries. They can rarely present with gaze evoked amaurosis. Okay. There is disc elevation. Again, there is no hyperemia. There can be subtle hemorrhages around the disc. And OCT is diagnostic, which shows posterior hyaloid traction. Next is a peripapillary CNVM or choroidal neovascular membrane. It can follow juxtapapillary choroiditis or Jensen's choroiditis and multiple causes. Okay, they present with visual deterioration if the edema and hemorrhages are at the macula. Per se, if there is no macular involvement, there is no symptoms as such. It simulates disc edema because there is disc elevation and some edema and hemorrhages around the disc. FFA and OCT help to identify the lesion. Are we clear till now? Can I proceed to the next group of disorders? Okay, so we'll be dealing with papilledema now. So causes of disc edema with preserved optic nerve function. I have chosen to name it this way because we are including malignant hypertension also. So when associated with raised intracranial tension, it is called as papilledema. And this is a picture of malignant hypertension in a 41-year-old male. You can see that there is bilateral disc edema, severe edema, so that there is macular exudates in the right eye, lot of flame-shaped hemorrhages, and subtle edema in the left eye as well. So how do you go about when you see a patient with bilateral disc edema with normal optic nerve function tests? Like I told you, the first test always should be to check BP. If the BP is very high, okay, let's come this side. The BP is very high, consider the diagnosis of malignant hypertension. I have put two boxes here, hypertensive optic neuropathy with or without macular star. Because we are usually of the notion that hypertensive retinopathy grade 4 usually has an optic nerve star, a macular star. But there are many instances when you cannot have a macular star. So it's always better to check BP instead of going the other way. Okay. So as of now, you can defer neuroimaging and you do a controlled control of pressure. Okay. You cannot bring down the blood pressure suddenly. It can cause ischemic optic neuropathy. We have seen such instances. Okay. If the disc edema is improving, then you continue your antihypertensive medication. And despite treatment, you don't see any improvement in disc edema even after 3 to 4 weeks, then you're probably dealing not with just malignant hypertension. Again, let's go back to square one. You are dealing with bilateral disc edema with normal optic function tests and your BP was normal. Then in both these cases, you plan a neuroimaging depending on the clinical profile. Okay, so what does the clinical profile mean? If the patient presents with focal neurological deficits or seizures, see, usually all these patients will invariably have headache. Give me a minute. Okay, so if there is focal neurological deficit, seizures, then you plan MRI with or without contrast with the help of your neurology colleague. And this will help you to diagnose ICSOL, cerebral edema, obstructive hydrocephalus, and so on. If the clinical feature suggests meningitis, in the sense there is fever or neck rigidity and altered sensorium, then you plan MRI with contrast. And then if it is suggestive of meningitis, then think about going ahead with lumbar puncture for opening pressure and analysis. In meningitis, usually the CSF analysis will be abnormal, and depending on that, you can classify it as bacterial or tubercular. If the opening pressure is very high, then you're probably dealing with IIH because you got the MRI normal here. There were no features of meningitis. Okay. Okay. Now the third clinical profile here is an obese fertile female. Okay. Usually 20 to 40 years of age, use of steroids, oral contraceptives, or use of any of the medications that I had mentioned. We are considering CVT, that is cortical venous thrombosis, or idiopathic intracranial hypertension, previously known as benign intracranial hypertension. Then we can do a MR venogram. So in CVT, you will see filling defects, and in IIH, you will see posterior flattening of the globe, stenos transfer sinus, and ventricles. So then you establish a diagnosis of IIH and then perform CSF analysis. All right. If you are having any doubts in this algorithm, I'm happy to solve your problems. Any doubts? Okay. So let's see one example. I want you to actively participate. I want any one of you to describe what you're seeing and tell me how do I proceed with this case. What are you seeing here?
Ma'am, here there is a blurred disc margins, ma'am. Looking
Yes.
like there is bilateral. Appear to be RNFL edema.
Yes, very good.
So there is, little veins are dilated and tortuous here.
Very good.
Ma'am, then we have to do first the refraction to rule out any hypermetropy, anything. Then
See, this is a very, very elevated disc.
very
Okay.
evident. Yes, ma'am.
So it's looking like grade 5 to me with lot of venous, tortuosity. So would you like to ask any history from this patient? Age, demographics, let's start it that way. Okay, so this was a 21-year-old girl. She came with very bad headache and nausea and vomiting. So what will you do next? You treat it like a normal ophthalmology case. How do you go about any case in ophthalmology?
Ma'am, we have to take the vision, then pupils.
Yes. Very good. So vision was 6/6 in both eyes. Pupils were normal.
Pupils. Blood pressure has to be checked in case.
Blood pressure was 120/80. Color vision was normal. So what do you think we are dealing with?
Could be if any
idiopathic intracranial
hypertension. Very good. So let's look at our table. Optic nerve functions preserved, right? And this doesn't have spontaneous, there are no veins only on the disc, all are obscured. So we're probably dealing with papilledema. Okay. So what happened later? So this is how a crescent sign looks. Can you appreciate this? Please remember this. This is a very nice sign and very easy to elicit. Even as neurologists, they would like to learn this. Okay. This echolucency that you see here is the crescent sign. Some people call it the donut sign. Okay. So this is the fundus image of what I just showed you. This shows the crescent sign, and we did a MRI which showed scleral indentation, empty cella, and flat ventricles, and then we did a venogram. It showed stenosed left-sided transverse sinus. Okay, so we are probably dealing with IIH here, and we started the girl on acetazolamide after CSF tap. Okay, so good, you did a good job. So next we'll go to causes of optic disc edema with impaired optic nerve functions. So there are a host of causes. Okay, so let's deal with one by one so that it's not too intriguing. Most important is inflammatory optic neuropathies. Some people prefer it to call demyelinating. Because I've included sarcoid in this, I prefer it to call inflammatory. Okay, there are more causes, but these are the 4 important ones. So we all know that multiple sclerosis is more common in Caucasian women, 20 to 40 years, and presents with unilateral acute loss of vision. But they usually have more of a retrobulbar presentation, but at least 30% of them can present with disc edema. So on MRI, you often see juxta-cortical periventricular infratentorial white matter plaques, what we call as Dawson's fingers, and short segment lesions on optic nerve that get enhanced on MRI. Okay, so here you have to remember, what you have to remember is usually presents with unilateral loss of vision. The vision loss is very steep, so they may present with PL vision. Okay. The next group of disorders is neuromyelitis optica spectrum disorders, more common in Indians, Asians, Africans. There is usually a sequential or simultaneous affection of the spinal cord in the form of transverse myelitis. If the posterior area postrema is involved, you can have intractable hiccups. Okay, usually the disease tends to be bilateral and the visual recovery is not as great as MS. They may also present with lower limb weakness. And the MRI is characteristically involving long segments. Okay, MS is a short name, right? MS. So it involves short segments. NMOST is a long segment, a long name. So it involves, remember it involves longitudinal extensive transverse myelitis and even the long segment of optic nerve. The whole of the optic nerve may look enhanced on your MRI. Okay, and there is a positive test for serum IgG aquaporin 4 antibodies. So let's deal with this case again. So you have to ask me questions and I'll tell you how to go about it. So what do you do now? Come on, you can ask me questions regarding the history, vision, all that. I'll answer and then you come to a diagnosis.
Oh, ma'am. What is the age of the patient and gender?
This is a 55-year-old male presented with sudden onset visual loss in the right eye.
Ma'am, color vision and
Color vision,
RAPD?
right eye vision is counting finger 2 meters. Color vision I could not perform. There is RAPD grade 2. Left eye vision is 6/6. Color vision normal.
Ma'am, any systemic comorbidities, diabetes or hypertension, anything?
No, he did not have any problems like that. No history of trauma also. No history of fever.
Ma'am, extraocular movements, any pain is there on movement up or
He
down?
had pain initially before the symptoms began on movement of the eyes.
We could be dealing with optic neuritis.
Yes. So yes, very good. We are looking at optic nerve functions which were certainly deranged in this. So we are dealing with optic neuritis. So I'll tell you the story of this patient. If you see here, this was at presentation, what we saw just now. Here, this is the RNFL map showing severe elevated disc, whereas the right side it is normal. This is the GCL map which is showing almost normal. That means the axons are still viable here. Okay. But left side there is some minimal yellow, that means maybe thin, not very reliable. So we did an MRI for this patient. Here you see some changes in the white matter. Okay, all right. Can you see this? Some demyelination plaques are there. Yes. So the next what we did was he did not consent for any treatment and he went back on his own. But after 6 months, he came back with sudden loss of vision in the left eye. But left eye, is there anything you see now? No. But right eye has developed some pallor. So now he has presented with retrobulbar neuritis of the correct of the left eye. So here you see that some thinning is there in the right eye and left eye is absolutely normal. But the GCL will give you a nice hint. There is severe thinning of GCL in both eyes. So when we did the MRI, we see everything is blown up, right? All these lesions have increased in size. So we did a serum IG4, IG aquaporin 4, and it came positive, and he was started on immunosuppressants. So these disorders, NMO and MOG, they need more immunosuppression than MS. Okay, they are more visually threatening diseases. So coming to MOG, here it can affect any age and gender, and the visual loss is more severe at presentation. It is a more diffuse condition, and bilateral papillitis is more common. So on imaging, you will see widespread diffuse, deep white matter and brainstem lesions, and it's more commonly associated with ADEM. Okay, often the optic nerve is the long segment is involved. So coming to sarcoid, disc edema can be due to inflammation or due to infiltration of the optic disc. Rarely, it can be due to raised intracranial tension due to neurosarcoidosis. Okay, what are the clinical features that will hint that this may be sarcoid that we are dealing with? Okay, there can be decreased tear production when you do a Schirmer's test. You can find granulomatous nodules in the trabeculum meshwork or tented anterior synechiae. You may see features of anterior uveitis, old anterior uveitis, which is usually granulomatous. You may find periphlebitis with candle wax drippings. This is why I was telling you that you have to do a full retinal examination in any case of disc edema. In the periphery, you might find some periphlebitis that may hint towards a sarcoid. You may also have a history of facial palsy. So on investigating, the usual tests that we do for sarcoid will come positive. And these also need some sort of immunosuppression. So after inflammatory, let's move on to ischemic. This is also a very common cause of visual loss in the elderly. Let's deal with one by one. Non-arthritic AION. Uh, the patient profile is usually age is 50 to 60. They usually have diabetes or hypertension, or they have some sort of a blood loss. Okay, they present with sudden painless loss of vision, usually discovered on waking up, and the visual acuity is not very bad. And on the examination, you'll find sectoral disc edema, and investigations, you know, all these things, you know. Okay, this is all theory. We'll go forward. In arthritic AION, they present with painful sudden loss of vision. Remember, there is scalp tenderness. So whenever they say they comb their hair, they, because of the tender temporal artery, they'll have pain. Also, they will complain of jaw claudication and multiple episodes of visual obscuration or amaurosis fugax. The visual acuity at presentation is severely diminished as against NAION. Here, the visual acuity may be very low, and the other eye also tends to be involved in these cases. The disc edema is pallid. These are all very characteristic, and you cannot make a mistake in this. Okay, visual fields you may not be able to perform in this because the visual acuity is very low. ESR and CRP is raised, and the temporal artery is tender and pulseless. Okay. Diabetic papillopathy also is a milder form of NAION, and the disc edema is not as much as in NAION. Also, the recovery is pretty good. But one important thing about diabetic papillopathy you have to remember is it is usually seen in patients in whom the HbA1c has been reduced drastically. So if you compare the previous HbA1c and today, you might find a very big difference between the two, indicating that this is some kind of an ischemic or nutritional insult to the optic nerve leading to ischemia. So there's one more case. If you want, I can zoom it a bit. Okay. There is a 56-year-old male with bilateral mild disc edema. Look at the discs and tell me what's going on here. Describe the disc edema.
Ma'am, there is like early disc edema. Nasal margins are little blurred and little hyperemic more in the right. There is starting of RNFL edema is there little.
Correct. What is happening to the superior pole in the right eye? That is not elevated, right? Only the inferotemporal pole is elevated.
So it could be like AAON, only the part is segmental involvement.
Very good. So this is how a sectoral edema looks. Okay. So what is the next step? What will you do now? So this patient has presented with bilateral mild disc edema. Visual acuity was 636 in both eyes. pupils, there is no RAPD because it's a bilateral condition. So what is the next step?
Many comobs has to be ruled out. Hypertension,
Yes, he's a
diabetes will be
diabetic and
causing this.
hypertensive, and he's taking nocturnal antihypertensive medications. Calcium channel blockers he's taking at night before he goes to sleep.
Okay, that also could be a risk factor. Nocturnal
Yes.
hypotension
Yes.
will be causing NaON. So here,
Correct.
I mean, vision is a little better. It could be non-arthritic. Usually, arthritic vision will be still more
Right.
less.
So what test will tell you this is NiON?
Ma'am,
Tell me, do a field
KAON usually could be associated with giant cell arthritis.
Yes.
And
In
HFA could show.
you will see more of a pallid disc edema.
Oh.
Here the pallor, excuse me, the pallor is not that significant. So we did a field and it shows superior altitudinal
effect.
So if you see, the edema is inferior and the field effect is superior, as we expected. So this is a case of bilateral NaON. So what are the take-home points from this case? One, optic neuropathies, NaION can be bilateral. Second, it can also present with macular edema in the left eye. See, can you appreciate the macular edema here?
Yes.
So just because there is macular edema, this is not neuroretinitis. This is NaION only. So this field is very helpful in understanding what it is. Okay, next case, 78-year-old male, severe headache since 5 days, sudden loss of vision in left eye, right eye is absolutely normal, vessels are all right, visual acuity is 1/60. What will you do? Can you describe this edema?
Ma'am, cup is
Margins are not
make out the
pallid disc edema.
Very good.
Is not.
Whoever said pallid disc edema is right, because whenever there's disc edema, you see hyperemia. Okay, whenever there is pallid disc edema, you should remember the cause of disc edema in this ischemic optic neuropathy is the ischemia only. There is so much ischemia, it is causing edema. Okay, so this is what we saw, and when we did the ESR and CRP, we found it is extremely high. So this is the diagnosis. I'm glad you're all getting the diagnosis right. Let's move on to infectious optic neuropathies. Cat scratch disease is a very fancy thing, but we don't see it very often in India. Usually there is a cat scratch history preceding fever, arthralgia, malaise. Usually they present with neuroretinitis. Neuroretinitis is a little older terminology. People, the neuro-ophthalmologists like to call it ODEMS or optic disc edema with macular star. Okay, OCT usually shows some epipapillary or peripapillary cells. You will see minute hyperreflective dots on OCT because nowadays OCT is gaining a lot of importance in neuro-ophthalmological disorders. Okay, and these patients will invariably be positive for IgM Bartonella. The next is syphilis. Syphilis, as you know, is a big masquerader and it's back. Okay, syphilis, the cases are raising. It's not a disease of the past. You're seeing a lot of syphilis nowadays. There's usually a history of chancre or maculopapular rash on the palms and soles. Then optic nerve can have varied manifestations. Like I said, it's a masquerade. You can have any sort of manifestation. Next is tuberculosis. India is the tuberculosis capital also. Okay, so there is usually a history of tuberculosis in the patient, or there is a contact. Can present with any form of optic nerve swelling. Usually you may not expect other features, but if you are suspecting tuberculosis, these tests will help you in identifying tuberculosis. So this is a patient who presented with diminished vision in her left eye, 35-year-old lady. Vision is 6/36 and RAPD is present. So we are dealing with neuroretinitis of the left eye, and there was a history of fever, and she has a pet cat. So we did a IgM Bartonella which came positive. Okay, this is not my own picture. This I have taken from the net. So what is difference in parainfectious optic neuropathy? So remember that parainfectious is not infection of the optic nerve by the organism. it is an autoimmune response to it. Okay, so it is more like an inflammatory optic neuropathy, but in response to a viral infection. It's usually the viruses that cause this para-infectious optic neuropathy. So there will be a history of fever or skin rash, or even a vaccination history can present with optic neuropathy, and it tends to be bilateral, and there is usually a disc edema with decreased vision. So it's more common in pediatric age group, and the recovery is also quite good. And they can have features of ADEM on MRI. And if you want to really know what the virus was, you can go ahead for a PCR test. So these I told are rare causes of disc edema because they usually present with optic atrophy. Optic nerve sheath glioma, thyroid eye disease can cause compressive optic neuropathy because they're compressing the optic nerve. Whenever the compression is within 1 centimeter from its entry into the globe, then it presents with a vascular sort of a picture. In the sense, it can have a CRAO kind of a picture. So they usually present with gradual vision loss, and if it is a very long standing disc edema, there can be optociliary shunts. Okay, and this is characteristic of optic nerve sheath meningiomas. There will be proptosis, you will see eyeball movement restriction, and the CT scan will help you confirm the diagnosis. But more often than not, they present with optic atrophy. I have included only LHO in here because the other types of hereditary optic neuropathies present with optic atrophy. Leber's also presents only with pseudo disc edema. It is not a true disc edema because they usually have peripapillary telangiectasias which look like it is edematous. Okay, so it's usually seen in males, and the sequential involvement is seen in both eyes. There is usually a centrocecal or a central scotoma that becomes total optic atrophy with time. So if there is peripapillary telangiectasia simulating disc edema, how do you think you can differentiate it from true disc edema? Is there any test, investigation? The answer is on the slide only. Okay, FFA shows no leakage of the dye, indicating that it's not a true disc edema. Next is toxic. Again, I have included only methanol here. Methanol, that also if you are lucky enough to see the patient at the time of acute presentation. Okay, the patient presents usually within 6 to 24 hours of ingestion of country liquor with sudden severe abdominal pain, systemic acidosis, and the typical fetid breath. The visual loss is profound and bilateral. And at this stage, if you're catching the patient, you will see bilateral disc edema, and the disc becomes atrophic very soon. Okay. So how do you manage disc edema? So since we know that there are a number of causes for disc edema, the management depends on what is causing the disc edema. So if it's a pseudo disc edema, you know whether you want to just observe it. ICSOL, you need a neurosurgical friend to come and help you with it. Malignant hypertension, as I said, slow, steady, hypertensive, antihypertensive treatment. Idiopathic intracranial tension, CSF tap, acetazolamide, VP shunts, all these are treatment options. Parainfectious, inflammatory, and demyelinating disorders, you need systemic steroids and then immunosuppressant therapy. Infectious, if you are able to identify what is the cause for the infection, you give the suitable antimicrobial along with steroids. NaION, till now there is no proper treatment established. AAION or arthritic AION, you have to jump in and treat with high dose systemic steroids to prevent the other eye from getting the similar issue. LHON also, we do not have really good hope with ibetanone, but it's just we can try. Then toxic optic neuropathy, nothing actually works. You have to remove the drug which is causing the toxicity. So what happens if you don't treat edema? There is loss of axons, and the eye usually goes into secondary optic atrophy. So we have a small baffling case. There was a 65-year-old lady who presented to us with diminution of vision in both eyes. which was 20 by 200, 660 almost. So can anyone of you describe what you're seeing here?
Disc is hyperemic. Margins are blurred. So with peripapillary sphincter hemorrhages.
Yes. So this hemorrhagic component is much more pronounced in this case compared to the others, right? Do you think the media is clear? There are some shadows, right?
Yes, ma'am. In the right, both days.
Both eyes. So this was vitreous hemorrhage and disc edema. So our first differential always anyway will be
Terson's could,
very good. Terson's. Can you describe what is Terson's syndrome?
Ma'am, when there is a subarachnoid hemorrhage, there will be seepage into the vitreous, and disc also could be hyperemic edema.
Very good. Yes, one differential is Terson's syndrome. My first differential again will be malignant hypertension. We'll check the BP. Okay, so we check the BP. BP was all right, 150 by 90. 150 by 90 cannot cause this sort of a picture. Okay,
arteries are also not attenuated, ma'am. Like, in sometimes could be.
Yes, direct. It's not that bad. So let me zoom one thing for you. Can you see this hemorrhage here?
Yes, it's looking like a rod spot.
Yes, very good. I'm so happy you said that. So we went back and saw, oh, this is a rod spot. And if you look at the rest of the retina also, it has not got that beautiful pink look that it should have.
Is it with blood disorder, ma'am?
He had a hemoglobinuropathy, ma'am.
Yes. So what we thought was, oh, something is going on. It is some cancer. Either it is leukemia or something is going on. So we did a blood profile. So the hemoglobin is less. Can you see the TLC there? TLC is skyrocketing. Platelets are marginal, but it's low. So then we did we referred the patient to a medical oncologist, and they did many more tests. And this was the PET scan. It shows a widely spread. Wherever you see this dark pink, no, there is where the tumors are. Here, everywhere. So this was some extranodal lymphoma that had spread everywhere in the body. And from the cervical lymph node that she had, they did a biopsy, which revealed marginal cell lymphoma, which was like metastatic like thing. So a simple eye test brought us to a diagnosis of a very dangerous tumor. That's all from my side. Any doubts? I'll be more than happy